So I think we are going to start. Thank you very much, everyone, for coming to our weekly innovative discovery series. We are very excited today to have Hilary Barnes from the School of Nursing at University of Delaware to give us a talk about policy-focused outcomes research for healthcare delivery by nurse practitioners. But before I introduce her, let me mention some housekeeping issue. So as you know, for CME credit, you must sign in and you must include your email and credentials. Don't miss our September 6th tech talk with Wekian from University of Delaware. And please note that our July 27th ID series, we will have Dr. David Chen from Krishna Care talking to us about firearm violence in Wilmington. So don't forget to register to help us prepare. And as always, the full schedule is posted on our website, DE-CTR.org. So thank you very much. We are very excited to have Dr. Barnes from University of Delaware here. Dr. Barnes is assistant professor in the University of Delaware School of Nursing and a senior fellow in the Center for Health Outcomes and Policy Research at University of Pennsylvania. She's also working as a nurse practitioner in the urgent care and emergent services at Cooper University Hospital in Camden. She got a PhD in nursing science from Widener University School of Nursing in 2013, and then completed a postdoctoral fellowship at the University of Pennsylvania's Center for Health Outcomes and Policy Research. And at the same time, she was a fellow at the Leonard Davis Institute of Health Economics at University of Pennsylvania. Lots of things. She has already a long list of peer-reviewed publications and has been invited to speak all over the country. And she has been and is a PI or co-PI on several federal grants as well as grants foundation. So thank you very much, Dr. Barnes, for being here. And we are very excited to learn more about health policy research outcomes.
Great, thank you very much. Can everybody hear me? All right, so well, I don't have to talk about myself because you did that nice introduction. So we'll get started. I have no conflicts of interest or financial relationships to disclose. And I'll just give a brief outline of today's talk. I'll talk a little bit of background about healthcare and how healthcare is changing in the United States. I'll talk about some of the policies that we look at when studying the nurse practitioner workforce, particularly scope of practice regulations and Medicaid reimbursement. I'll present the results from 3 studies, from 3 recent publications of mine, 1 cross-sectional study and 2 longitudinal analyses. And then we will wrap up with discussion implications, and I'll talk about some of my future work and interests. So the U.S. healthcare system is changing, and some of the major drivers of these changes are population changes. So our population is getting larger, it's getting older, more individuals are living with chronic illnesses. Additionally, with the Affordable Care Act and healthcare reform, many individuals, millions of individuals have gained health insurance coverage, so they're entering into the healthcare system, some for the first time and some from after a little bit of time away. I want to avoid knocking that over. And also in terms of healthcare delivery models, reimbursement is changing, and there's a lot of changes going on with how practices and providers are being paid for their services. And currently we're really still in a majority fee-for-service system. About 2/3 of healthcare is still paid under a fee-for-service basis, but value-based care and value-based reimbursement is coming, and that's changing how practices are looking at how they're going to deliver care. So we're seeing the development of these ACOs, these patient-centered medical homes, and underlying all of that, so with these changes in the population, changes in health insurance availability and reimbursement changes, we're seeing an increase in patient demand and a greater need for healthcare. And underlying all of that is still some access to care concerns, particularly in settings that have traditionally seen some challenges like primary care, where there are debates surrounding how many providers are available to provide primary care, whether it's physician, whether it's nurse practitioners. And then rural settings have traditionally really struggled to get primary care providers as well as a lot of specialty providers out in those areas to deliver care. And Medicaid beneficiaries they often struggle getting access to care due to low reimbursement rates. Research has found that due to low reimbursement rates, physician practices often don't accept Medicaid, and when they do, Medicaid patients often struggle getting appointments. So with this increased patient demand and changes in the healthcare system, we have to think about how these evolving models of care are going to impact the workforce. So how are we going to use the workforce, and how is the workforce going to change patient demand to increase access and improve outcomes? And as healthcare is changing, we're seeing more of these interdisciplinary team-based models of care to use to deliver care to improve care delivery. And as these team-based models of care kind of develop and become more prevalent, it's expected that nurse practitioners are going to play an increasingly important role in delivering care within these models of care. So a little bit about nurse practitioners for anybody who may not be familiar. There are about 234,000 nurse practitioners in the United States now. And I think in the state of Delaware, there's around 1,000, maybe a little bit more, nurse practitioners. There's a large body of evidence that shows that care delivered by nurse practitioners is high quality and it's safe, and outcomes of nurse practitioner delivered care is equivalent to physician delivered care on a number of outcomes. NPs can deliver the majority of primary care services in the ambulatory setting, and costs of care for NP delivered care has been found to be lower than physician provided primary care. A recent survey found that nurse practitioners often work in rural settings more frequently than physicians, and they also care for Medicaid beneficiaries more frequently than physicians. And more newly, specialty care has been having an increasingly interest in embracing roles for nurse practitioners within their settings. Then on the patient side, patient satisfaction with NP care is high, and willingness to be seen by NPs is growing. So we know that NPs deliver high quality care. So how are we going to optimize them in the ambulatory setting? And some of these questions we can ask in the inpatient setting as well, but most of this work that I've completed has been in the ambulatory setting. So what we don't really know is that as these models of care change, as nurse practitioners, the supply increases and become more prevalent in as a provider for care, is how these configurations of providers within these practices are changing. What are these groups going to look like? What are these teams going to look like? And when are physician practices incorporating NPs into their practices? So really, we're looking at employment trends of NPs in primary care and specialty practices. And then we also have to look at how are these state-level regulations, particularly scope of practice and Medicaid reimbursement, going to impact the workforce and impact where NPs work and how practices may use them. So we really need to look at how we're going to optimize this segment of the workforce to deliver care. And before I get into the studies, I'm just going to talk briefly about the two policy contexts of interest of mine. The first is scope of practice. And scope of practice are the state-by-state regulations that dictate how an NP can practice and or prescribe medication. I specifically look at the collaborative agreements with physicians. And Delaware is a full scope of practice state. And I know it's recently a new scope of practice state, so there's some changing. But what these collaborative agreements are is there are agreements that nurse practitioners need to have with the physician to practice and or prescribe medication. In some states, a nurse practitioner needs one for both aspects. So what we did was we categorized our states into three categories. We categorized them into full scope of practice. So the NP is independent, no collaborative agreements. The nurse practitioner can go out and work where he or she would like. These reduced scope of practice states are states that are kind of in the middle. A nurse practitioner can practice independently, but they need the prescriptive authority collaborative agreement to prescribe medication. So they're still required to be tied to a physician. And then these restricted states, a nurse practitioner needs the collaborative agreement to practice and or prescribe medication. There's been a lot of discussion in recent years to remove these scope of practice restrictions, and it's supported by many, including the Institute of Medicine, the National Governors Association, and the Federal Trade Commission. And removing these scope of practice restrictions have been discussed as a way to optimize the workforce and really let nurse practitioners provide care to at the top of their training and the top of their education. A recent report from the Brookings Institute came out and actually found that having scope of practice restrictions limits practices' ability to kind of switch up their provider mix. So it's more difficult for practices to bring in nurse practitioners to provide care. So the scope of practices put some restrictions on that, and I'll talk about why that may be more at the end. And research has found that removing scope of practice restrictions actually has been found to be beneficial. So in states that have full scope of practice, there have been a greater availability of nurse practitioners to work in primary care. So NPs show up more in primary care when there are no restrictions. And one of those studies, I'll talk about some findings of mine. And in states that have received, in states that have removed scope of practice restrictions, there has been no decrease in quality of care. So quality of care is no different in states with full scope of practice, where removing scope of practice doesn't diminish quality of care or patient outcomes, and having these scope of practice restrictions doesn't improve quality of care. And so there are these other barriers put on NPs. And then the second is Medicaid. Medicaid expansion, as we all know, has happened. It's happened in 34 states. Almost 12 million people have been covered newly under Medicaid expansion. And this is important because more individuals are coming in with health insurance. And as I said previously, nurse practitioners have been found to take care of Medicaid patients more than physician practices. So it'll be important to use nurse practitioners to care for these individuals. And looking at the Medicaid fee-for-service reimbursement rate for nurse practitioner services, these reimbursement rates can vary from 75% of the physician fee-for-service rate in some states up to 100% in 100% of the physician fee-for-service rate in other states. And if anybody didn't know, Delaware reimburses NPs at 100% of the physician fee-for-service rate. So the first study that we're going to look at looked at the influence of these state scope of practice policies and the Medicaid reimbursement rate on whether an NP works in primary care, and then we also looked at practice acceptance of Medicaid. This was a cross-sectional design, and we used logistic regression to look at our outcomes. The data that I used for this study is the 2012 SKNA data. The data is now called IQVIA 1Key. They've changed the name and how they've collected some of their data. But what this data primarily is a national database of physician practices. So it includes pretty much all ambulatory practices in the United States, many practice level variables and information about the practices in this data set. But the really nice feature of these data is that you can identify who the individual providers are. So I can see how many physicians are in the practice. I can see how many nurse practitioners are there. I can see how many physician assistants are there. And then we also merged with the area health resource file, which is county level information from HRSA that provided us with geographical and socio-demographic variables of the counties where these practices were located. So the first analyses we did, we looked at nurse practitioners and whether having full scope of practice, so whether the state allowed for independent practice versus any restriction. So we dichotomized the variable in this study. We looked at almost 60,000 nurse practitioners, and we found that NPs had a higher odds of working in primary care practices in states with more favorable practice environments. So when NPs worked in a full scope of practice state, the NP had a higher odds of being in primary care, and that odds was 13% here. Maybe I can do this here, 13%. But then when the state also allowed for 100% Medicaid reimbursement for NPs, that odds increased to 20%. We looked at the practice level. So we looked at over 250,000 primary care and specialty practices, and we looked at Medicaid acceptance, which was our outcome, to see if having a nurse practitioner improved the likelihood that a practice accepted Medicaid, and we also looked at the Medicaid reimbursement rate. And we found that practices had a 10% higher odds of accepting Medicaid if they had an NP, but if that practice was also located in a state that reimbursed the NP at 100%, that odds went up to 23%. The next study that I'm going to talk about is a descriptive longitudinal analysis looking at trends in NP employment in primary care in rural and non-rural settings. Again, I used the SKNA data from 2008 to 2016, and we used the area health resource file also for this. So what we first did was we looked at the total number of providers in these settings. So across the top of the gray is nurse practitioners, the orange is physicians, and the blue along the bottom are physician assistants. And what we found was that from 2008 to 2016, nurse practitioners constituted an increasing proportion of primary care providers in both rural and non-rural settings. So these darker lines on the left are the rural settings. And by 2016, nurse practitioners constituted almost 25% of primary care providers in these settings. And that was a 43.5 relative increase compared to 2008. At the same time, physicians in these settings decreased by 12.8%. Similar findings happened in non-rural primary care, with nurse practitioners constituting approximately 23% of primary care providers in non-rural settings by 2016, and physicians decreased by 11.8%. And just as a reminder, these are physician-led practices. And then along the bottom are physician assistants, and they actually stayed pretty flat in primary care during this time period. Next, what we looked at is we looked at the percentage of practices that employ nurse practitioners and the average number of nurse practitioners within these practices. So along the top are the two lines are the percent of practices that employ nurse practitioners. So the blue line is rural primary care practices, and the orange line on the bottom is non-rural practices. So you can see that nurse practitioners are a much higher percentage of practices in rural settings employed nurse practitioners compared to non-rural settings. But there was growth in both settings, with nurse practitioners appearing in about 43% of rural primary care practices by 2016. And then along the bottom, the gray bars are rural settings, and the yellow bars are non-rural settings. And these are the average number of nurse practitioners per practice. And you can see growth occurring from 2008 to 2016 in both settings. So this is showing us that practices are adding nurse practitioners for the first time to their practices, as well as adding more nurse practitioners to their provider staff. We then looked across scope of practice. Again, the nurse practitioners appeared in rural settings in a higher percentage of practices than in non-rural settings. And the top three lines across the top are our rural practices. And we'll look at those first. So the blue line at the top are full scope of practice states. So these are the independent scope of practice states, and they had the highest percentage of practices with nurse practitioners. The gray line are the most restrictive states, and they had the lowest percentage of practices with nurse practitioners. And that orange line in the middle are the reduced scope of practice states. So the states where a nurse practitioner can practice independently, but they need that collaborative agreement with a physician to prescribe medication. And as you can see, the highest growth, we had growth across all scope of practice, but the highest growth actually occurred in our more restrictive states, with almost a 50% relative increase of practices with nurse practitioners in these reduced scope of practice states, where the percentage of practices with NPs in reduced scope of practice states almost matches full scope of practice states by 2016. And what I'll say is we ran some regressions and we looked at the differences between these rates of growth, and the rate of growth between the full scope of practice and the most restrictive states was statistically non-significant, but it was statistically significant between the full scope of practice and the reduced scope of practice states. And the three lines along the bottom are non-rural settings, and you can see similar trends kind of mirroring in those settings as well. And so then the third study I'll quickly talk about is similar to the one I just talked about, but this is specialty practices. And we looked at nurse practitioners and physician assistants in these settings. So this study was looking at trends of employment in these physician specialty practices. And again, I used the same data for these analyses. And what we found was that, again, we found greater, a greater presence of nurse practitioners in these specialty practices over the time period. And by 2016, almost 20% of specialty practices employed at least one nurse practitioner, and that was a 33% relative increase. In our sample, medical specialties relied more on nurse practitioners compared to the surgical specialties, with 16% of medical specialties employing a nurse practitioner compared to 7.7% of surgical specialties in 2016. I also have the numbers for physician assistants here. So comparatively, physician assistants appeared less in these specialty practices. 14% of our practices by 2016 employed a nurse practitioner, employed a physician assistant, and that was a 23% relative increase compared to 2008. But opposite of nurse practitioners, the surgical specialties actually employed more physician assistants than nurse practitioners, with 15% of surgical specialties employing a physician assistant by 2016 compared to about 10% of medical specialties. And along the bottom, I have the top 5 specialty practices that employ nurse practitioners, which are OBGYN, cardiology, gastroenterology, psychiatry, and neurology. And comparatively, the top 5 specialty practices for physician assistants were dermatology, orthopedic surgery, GI, cardiology, and neurology. So you can see those surgical practices are relying more on PAs than nurse practitioners. So discussion and implications. These results have implications for the current healthcare environment, with more individuals coming into healthcare with health insurance, increased patient demand. These results, particularly from the first study, could help inform scope of practice debates and changes in Medicaid reimbursement. So we found that full scope of practice environment and these more favorable environments that reimburse nurse practitioners at a higher rate, we found more nurse practitioners working in primary care, and we also found more practice Medicaid expansion. This will help inform some scope of practice reform efforts to remove scope of practice restrictions on NPs to really help these NPs move into these areas of greatest need and help inform practices to use NPs to deliver care. Our study found that practices were more likely to accept Medicaid when a nurse practitioner was present and the reimbursement rate was higher. And that aligns with other research that found that access for Medicaid patients, this study looked at actually getting appointments. So Medicaid patients had an easier time of getting appointments when the practice had an NP, but only when the state allowed for full scope of practice. These results can also help inform some reimbursement policy changes, and that changing some of these reimbursement and increasing the reimbursement rate for nurse practitioners to bring it up to the physician level for Medicaid would help incentivize better use of nurse practitioners with primary care and incentivize practices to accept Medicaid and bring in these patients and provide access to care. Traditionally, Medicaid has lower reimbursement than Medicare and private insurance, which is one of the reasons why physicians don't often, well, I'm going to say not often, but while research has found that physician practices sometimes don't accept Medicaid because of the lower reimbursement. And so then when you're reimbursing nurse practitioners, even at a lower rate, there's less of an incentive. So we can bring that up. There might be more incentive to accept Medicaid and increase access to care for these patients. The other 2 studies, we found that nurse practitioner presence is growing in both primary care and specialty care. They're constituting a larger proportion of providers, and that these physician practices are embracing more interdisciplinary models of care, and they're moving more towards what looks like team-based models of care, or what could be set up as team-based models of care. And some of these potential drivers for the growth that we saw, we hypothesize are that payment reform is happening, so we're moving towards that value-based care. And these value-based, team-based models of care have been found to be more efficient in terms of delivering care. So we're seeing these practices moving towards these interdisciplinary models of care that are more efficient. And labor costs within practices have been found to be lower in practices that maximize and optimize NPs and physician assistants in their practices. So this could also be a potential driver of growth. And I want to talk about some of the trend differences across scope of practice. So we saw the highest percentage of practices having nurse practitioners in these full scope of practice states. And what I'll say about the analysis is we only looked at states that didn't change scope of practice during this time. So everybody in each category had full scope of practice the entire time. They had restricted scope of practice the entire time. And so in these full scope of practice states, we see the highest percentage of nurse practitioners being in these practices. And these are states where nurse practitioners really can work to the top of their education. They really can be used optimally within the practice. One reason we think that the growth rate may be lower is that also in these states, and these aren't captured in these data, also in these states, nurse practitioners may have other employment opportunities, such as independent health clinics, their own practice, or maybe a nurse managed health clinic, or some kind of other practice environment where they don't need to have that collaborative agreement. So they might not be, these providers who aren't in these data sets can contribute to the supply of providers in these states. I'll go next to the restricted scope of practice states. So these states, we saw the lowest number of practices, or the lowest percentage of practices with nurse practitioners in them. And we think that the reason could be for a couple reasons. One, these nurse practitioners, because of the practice restrictions, can't work as optimally as they would if they had less restrictions. So their productivity, their value, their efficiency may not be as strong in these practices and in these states, just because they can't do as much. Anecdotally, some of the restrictions could be that there's a supervisory relationship between the physician and the nurse practitioner, where the physician is required to sign all the notes, or maybe also required to see the patient along with the nurse practitioner, which when you're trying to manage a practice is quite inefficient. And so these nurse practitioners may have some sort of productivity ceiling within these practices that limits practices' incentive to hire them. Additionally, in a lot of these states, these collaborative agreements have maximum ratios, so physicians are only allowed to collaborate with a certain number of nurse practitioners at the most, and physicians aren't legally obligated to go into these agreements with nurse practitioners. So if every physician in the state can only collaborate with, say, like 4 or 5 nurse practitioners, you have this legislative ceiling of the supply of nurse practitioners that can be available in these states. And so that's one of the reasons we're thinking that those states have the lowest percentage of nurse practitioners. And then in the reduced scope of practice states where we saw the greatest growth, we hypothesize that in these states, the nurse practitioner needs to be connected to the physician, but they can do a lot more in the practice. So their productivity, their efficiency, their value to the practice is a lot more. And so these practices have more incentive and more interest in hiring them into the practice. So some limitations, and this is the same limitations for all the studies. Like I said, these NP-focused practices, such as independent practices and nurse managed practices, are not included. So we don't know what's happening with that segment of the workforce. These data are challenging to come by if anybody was going to ask me about that. It's hard to know how many nurse practitioners are working independently. That data is not collected. And we can't determine employment status or how these providers are being used in the practices. So we don't know if they're full-time providers, if they're part-time providers, if they have their own patient panel, how they're being used within the practice, which would be very interesting to know. So in conclusion, for these studies, so these favorable practice policy environments are associated with greater employment of NPs in areas of greatest need. So primary care and practices that accept Medicaid. NP presence is increasing nationally in both primary care and specialty practice, and NPs have a growing presence in rural settings. Physician practices are embracing these more interdisciplinary provider mixes. And with the optimal use of the nurse practitioner workforce, there's potential to improve care delivery and access to care, as we saw with some of these results. So what I'm working on next is kind of an extension of some of this work. I have a small pilot grant from the School of Nursing at the University of Delaware to examine patient outcomes, looking at differences in outcomes for patients seen in practices with and without nurse practitioners, and in practices that have these kind of interdisciplinary configuration of providers. And also what I'm interested in is kind of connecting these clinical partnerships. So exploring the clinical practice activities that NPs do within the practice that I can't get out of these data that contribute to the value and quality of care in these settings. And so I'd be interested if anybody has any burning clinical questions that they want to have answered. How to improve care in your clinical setting. I'm open to questions and interests. So that would be the next step. So we're seeing what MPs are doing in the workforce, but we need to drill it down to kind of see what they're doing on the ground to improve outcomes and improve quality and access to care. I just want to thank my mentors and co-authors on these papers. And then I also want to thank my funders for these studies. And I am a little early, but I'll take questions. And thank you for your attention.
I have several questions. Please interrupt. Thank you very much for this. I'm not quite sure I understand why would anyone be against saving the full practice of nurse practitioners. What are the forces there that are acting against the full practice? What are the
So I can talk about Pennsylvania because I live in Pennsylvania and I've been kind of involved in their efforts to remove scope of practice restrictions. And I think it is pretty similar in other states where this is happening. But there's a lot of support to remove scope of practice restrictions. AARP supports it. The Hospital Association support it. The Federal Trade Commission supports it. The National Governors Association, IOM. Who else? Yeah, the AARP. So there's a lot of support behind it, but there's a lot of pushback from a lot of the physician organizations. So I'm not talking about just like all physicians kind of on the ground, but these large organizations are pushing against it, and they're citing patient safety and quality of care. And that if you remove these scope of practice restrictions, care is going to be diminished, patients aren't going to get the care they need. But the research, there's a large body of research out there showing that this is not the case, that when you remove these scope of practice restrictions, care isn't diminished. And when you compare states with restricted scope of practice and states with full scope of practice, quality is the same. So having full scope of practice is it's not harmful to patients. And in fact, some of this research and other research is showing that access is better, costs of care are better, quality is better. So it's really kind of political at this point. And so that would be my answer to that question. So, yeah.
Hi. I'm curious about the influence of educational bodies within states. So the number of NP programs that you have. Perhaps you have colleagues, collaborators within that to advocate at the line. I only think about it because I'm a pharmacist, and I know that there are a lot of issues that we run into when there are no schools of pharmacy within a state, Delaware being one of them. So what does the influence of concentration of educational programs have on things such as access and scope of practice?
Yeah, that's a good question. I don't know if there's a statistical answer, but what I can say is that in efforts that I've seen, that in Pennsylvania, where there are a number of nursing schools, a lot of large nursing schools, the deans have come together and have put a lot of effort into talking to legislators about removing scope of practice restrictions. So I would imagine maybe anecdotally that having more schools of nursing might be beneficial, but in a state like Delaware, in terms of nursing schools, we have some really good big nursing schools. But Delaware's already full scope of practice, so it's already done. And so I don't know, but I would imagine having more schools of nursing behind you probably would help you. In terms of pharmacists, I don't know how to do that. But the other thing I wanted to say, I wanted to talk about the G&E. You said something about, let me come back to that and think about it, because you said something and I wanted to say something, but now I've lost it. So, yeah.
The National Organization of Nurse Practitioner Faculties is way behind this, and so I think while there's a higher, I'm sorry, I should have. I'm Susan Kennedy Buck. I work with Hillary. I'm the director. I'm the president of the Nurse Practitioner Association of the state. But the National Organization of Nurse Practitioner Faculties is very much in favor of the full scope of practice, obviously. And so, as an organization, like some of the other organizations that Dr. Barnes mentioned, we are also in favor of that because we truly feel like using nurse practitioners to the fullest extent of their education and training is the most important thing to do to allow them to. We're all looking at satisfaction. We're looking at it as a measure of being happy and doing what we do. And part of that has to deal with doing what you were trained to do. Mm-hmm. So her work is spot on in terms of what we're trying to make sure that everybody knows that nurse practitioners are growing and constantly.
Okay.
So the studies that you mentioned related to outcomes of patients, will it be a prospective study or is it something that you are looking retrospectively using?
Of the new study
Yes.
that I talked about,
Yes.
it's would be older, retrospective data from 2015. And that study will be cross-sectional at this point. Hi, yeah.
Do you know why NPs are utilizing certain specialties? Because you spoke about PAs are more in the surgical line, and then NPs are more primary care medical. Do you know why? Like there's a certain propensity for one NPs to go one way and PAs to go another way?
I don't know specifically, but if you think historically how the roles were developed, nurse practitioners were developed in kind of a primary care capacity, in a more medical capacity. So my thought is that they could be brought into some of these medical practices to help with maybe deliver some primary care in these settings, but help with the medical portion where the physician assistants historically were trained to work more alongside of physicians in a surgical setting and do procedures. Their role is obviously changing, and they recertify in primary care, and so they do get that training in primary care, but I think it's historically how they were trained, and maybe that some of that is still showing up in which, physician specialties that are comfortable with using them, or maybe it's a little bit of familiarity too.
Hi, have you ever looked at like the, less emergent, pop-in centers like the MedExpress? Do they utilize NPs as, at similar rates or?
I didn't look at specifically like trends. That actually would be really interesting. I work in urgent care, and we use both nurse practitioners and physician assistants. And then anecdotally, I know a lot of nurse practitioners who work in these settings. I do have that. I could pull it out. That would actually be really interesting to look at. Yeah. But I would imagine so. Just in terms of supply and labor costs, and but it would also depend on the state how they would get that collaborative agreement. But whether the physician's present when the collaborative agreement is happening or not, that's another discussion.
And is it the states that actually determine whether you're full scope or restricted or reduced? That's the state government.
That's at the state level. But what's interesting is there's a body of work coming out of Columbia right now, and the researcher there, her name's Lucine Pogosian, she's actually looking at the practice level. So she's looking at restrictions that practices put and institutions put on nurse practitioners above and beyond what the state allows. So you could work in a full scope of practice state, but you might go into an institution that says that kind of limits what you do. So she's starting to piece that out and pull that out and look at that.
I was going to comment that I think that's actually a great thing to look at, because I think here at Christiana, I see the inpatient side of things, not the ambulatory, but I would say our scope of practice for our NPs is more restrictive than the state would necessarily allow. But part of that challenge may be that I think the state PA scope is more restrictive than the state NP scope. And since we employ both and use them interchangeably, we can't really, we have to have a single scope. So we scope probably to the PA laws and not to the MP laws.
Yeah.
So it would be interesting to know how practices adapt, particularly as the state law changes. Do they update the scopes themselves?
And an interesting thing about Delaware, which is kind of more common these days, is when states are removing scope of practice restrictions, they put in this clause that the nurse practitioner has to have a collaborative agreement for, if they're a new nurse practitioner, they have to have it for, in Delaware, I think it's 2 years or 4,000 hours. So for the first few years that they're working, they almost look like a restricted state, and then they become independent. And they're called transition to practice hours, and they're brand new. So I think one of the first states to use them would be is New York or Minnesota, but they just went to full scope of practice just a couple years ago. So, and I think there's only like 3 or 4 states. Pennsylvania is suggesting it, and so it's kind of this new thing that has come up in these scope of practice reform debates, and that will be really interesting to see what the workforce is doing, what institutions are doing. If you look restrictive for a couple years and then you're independent as an individual provider. So that's definitely very interesting.
I'm not sure I may have missed it, but how many states have full practice?
If I get this wrong, Susan, I think it's 23.
It changes every day.
23 plus DC. It's either 22 plus DC or 23 total. Yeah. No, it's less than half. Yeah. And there's about, I think, 3 or 4 states that have their full scope of practice, but have these transition to practice hours. And they vary from state to state. How many, I think Minnesota is 3,000 hours, Delaware is 4,000 hours, Pennsylvania is like 3,600 hours. So they vary. And is it for new nurse practitioners to the state or new nurse practitioners to the practice? It's a lot of variables.
And did the states who didn't expand Medicaid, they have less practitioners or nursing staff?
No, that's a good question. The second study that I presented, looking at NPs in rural, non-rural settings, we also looked at we broke that out by Medicaid expansion, and it's in the paper, so you can see that, but it actually didn't. The trends, I mean, the presence of NPs grew in all the states, but the trends were different across the two. So that really, Medicaid expansion didn't really have much of an effect on that. And we just looked descriptively. So, well, thank you.